about fecal incontinence, and we'll get started. So this is us. As I said, we're at colon rectal specialists. So first of all, I wanted to just introduce the subject of fecal incontinence and pretty much eliminate the stigmas related to it. Most people don't talk about it because it's embarrassing. They're shy. They're embarrassed about it. It causes a lot of sources of discomfort and embarrassment. But a lot of people experience it, and most people don't even talk to their doctor about it. As you can see here, it says that 54% of people don't even talk to their doctor about fecal incontinence. What people tend to do is they just adjust their lifestyle related to it. They may not go out as frequently. They may know where the bathrooms are at all times of day. They experience fecal smearing. They don't necessarily call it fecal incontinence, but it might be fecal smearing or accidents related to gas or something else. So there's lots of things that people experience, but it is very common. I just want to completely eliminate that stigma from the get-go. So the agenda for the day is that we're going to talk about bowel control. We're going to discuss about how bowel control works, our control pathway, and our pathway to helping you through this process. We'll talk about treatment options, and specifically we'll talk about the InterStim device, and then we'll open it up to some questions and answers. So as I said, it's very common. 1 in 12 adults have fecal incontinence. It's so common that it's actually more common than asthma or Alzheimer's disease. And we talk about asthma and Alzheimer's disease on a daily basis. There's tons of research in those fields, but lots of people don't talk about fecal incontinence. It's incredibly common. 20 million people in the US suffer from fecal incontinence, men, women, the like. It causes embarrassment, depression, lower quality of life. So it is a pretty important subject. So let's talk about what's normal and what isn't. So as we age, our muscles get weaker, our tissues get weaker. There's definitely some differences as we get older, but incontinence should not be a normal part of the aging process. You shouldn't be having to plan your activities around the bathroom and monitoring what you eat. A lot of my patients say that every time they eat, they have to run to the bathroom. That's not a normal thing. So that's something that you need to talk to your doctor about and discuss how we can diagnose and possibly treat these issues. A lot of patients, like I said, use these pads or undergarments to help prevent the accidents from getting in their clothing, and it does cause the sources of embarrassment. So let's talk about the bowel control pathway. So basically, as you eat food, it goes through your small intestines, it gets digested through the intestines, and then it goes into the colon. The colon is the last 5 feet of the intestines, and then the rectum is the last 8 to 10 inches. The rectum acts like a reservoir, and it holds the stool in before you decide to pass it into the toilet. And so what happens in the rectum is that there's this nerve signaling pathway between the rectum and the brain, and signals get sent to the brain saying, oh, my rectum is full, I need to go to the bathroom. So either you send a signal back saying, okay, it's not socially acceptable, I'm not around a bathroom, let me hold it, or you're ready to go and you allow your sphincter muscles to relax so you can evacuate. So that's this signaling pathway that kind of is continuous throughout this process. And I want you to keep that in mind as we go forward. So then what is fecal incontinence itself? It's a recurring condition that you're not able to make it to the bathroom in time or notice that you're having accidents. So there's 2 types of fecal incontinence. One of it is urge, where you have to rush to the bathroom and you just can't make it in time. There are other times where it's passive incontinence, where you don't even realize it's happening and you have leakage of stool. So these are the 2 types of things that we treat. As I said, it is more common with diarrhea. If you have loose, watery stools, it's easier for that to pass. There are patients that experience gas incontinence, and those are patients that just pass gas without planning on passing it. So there's a lot of different types of fecal incontinence that we can discuss with you when we're doing your evaluation. Good news is there are treatments available to you, so you can get back to your quality of life. You can get out of the house, feel like you can, resume your normal quality of life. So the way we start the process in terms of our pathway, at the colorectal specialist, we come up with a diagnosis, we move on to some conservative management, and then go on to advanced therapies. Now, Dr. Gentry is going to touch a little bit on how we come up with the diagnosis and the different types of methods we can use to diagnose fecal incontinence related to the muscles and the nerves. Dr. Gentry?
Thank you, Dr. Coury. So I want to reiterate what Dr. Coury said about this problem, in that it is something that many folks do not want to talk about. But trust me on this. We have heard it all. We have heard it all. And I think the most important thing in the workup and the diagnosis of the problem is the history and physical. And it's the basic element of what we do. Before we even get into some of the testing, each individual patient has a story. And for example, that story could be that, you've had 4 children. There was a 4th degree tear. The story could include radiation in your history. There's just several things that have to be discussed before even getting to workup for the fecal incontinence. So I think that's the first thing, that we listen to what you have to say. We talk to you about your issue, and trust me, it's nothing we haven't heard before. When it comes to the actual physical exam, that's also very, very important, because there may be some problems that we can fix that are fairly quick to do. Meaning, if you've had hemorrhoids and they're prolapsing, those are things that we can address in the office that may be attributing to some of your symptoms of fecal incontinence. So once you do the history and physical, and we have a clear picture, the next important point you should take away from this is that this is a team approach, in that you may see one of our partners, you may see me, but you also see the nurse, the assistant, our pelvic floor nurse who's been with us for 20 years. And so it is a team approach. What are the tests that we would do to help identify things? Well, the first is an ultrasound to look at the sphincter anatomy. The second test we would do is something called a non-invasive EMG, and that's exactly what it is. It's non-invasive, and it really looks at the neurophysiologic pathway of the sphincter muscle. The other thing we look at is the anal manometry, which looks at the physiology and the feedback of the sphincter muscle. And we'll also do what's called a balloon reflex test, which helps to evaluate the rectal compliance and the function. And so once we have that opportunity to do the history and physical and do those pelvic floor tests in our anal physiology lab, then we can go on to giving you an idea of what those treatment options are.
Very much. Yeah. So after we go to the diagnostic studies, we usually move on to conservative therapy, because most of the time conservative therapy will help, as Dr. Gentry mentioned. So moving on to that, we start off with dietary modifications. So like I said earlier, liquid stool is easier to pass. It's harder to control things that are liquid in nature. If your muscles are weak, if they're not strong enough, then the liquid stool can easily cause accidents. And that's why we start off with dietary modifications, medications. We'll start with fiber bulking agents, bulking up the stool so that it's easier to hold on to. Fiber tends to act like a sponge. It absorbs water, and it helps you hold on to the stool a little bit better. Medications such as Imodium can also kind of artificially constipate you, in a sense that it will help prevent those accidents as well, and go from a loose stool to a more firm stool. Other things that can be done are physical therapy, biofeedback. These are done by specialists, by specialized physical therapists that focus on the pelvic floor and helping you regain that control when it comes to Kegel exercises and things like that. The great thing is, conservative treatment does tend to work about 70% of the time. The problem is it doesn't tend to be as durable. Most of my patients who try this conservative therapy, it'll work for maybe 3 to 6 months. It may stop working after a year, and they do all the things that they're supposed to be doing, and yet they still get those accidents. But we always try that first before we jump into anything more aggressive. So after we do the conservative therapy, and if that does fail, then we end up with some more advanced therapies. There's surgical options. There's the minimally invasive approach that we're going to talk about in a second. So if the conservative therapy does not work for you, then that's when we need to talk about other options. So just think of this as a pathway. You know, there's a light at the end of the tunnel. It's not just one thing and then you're done. Think about the pathway as a continuous program to help you throughout your life. So surgical options, there's lots of different types of surgical options that are historic and that are available. Some of them have kind of gone out of favor. And I was going to have Dr. Gentry talk a little bit more about a lot of these surgical options that were used in the past, but unfortunately are just no longer used today. Dr. Gentry?
So I think the one question that I would say that I get a lot and have gotten a lot over the years is, do I need a colostomy? I mean, is there that point where it's just beyond reproach that you have to go to that extreme? And that's a big fear that patients have. And, you know, I want to reassure those who may have that concern is that there's a lot of different layers of treatment and surgical options that are out there that are more effective. Like I mentioned, there may be some simple fixes for anal rectal pathology. You know, there's some things that we can do in that regard. But getting to surgery, I mean, we've tried a lot of different things. I'm not saying that they've all been successful. We've had, in the past, we've used things like radio frequency, thermal sort of scarring of the tissue. We've used injectables into the anal tissue to help, you know, bulk the tissue. We've done artificial bowel sphincters, which were, you know, they were successful, but very invasive. And I mean, it's very likely that most of those patients got an infection. The other mention was a sphincter repair. You know, women who've had children and who have damage to the sphincter muscle, their chance for success has improved with some of the newer technologies that Dr. Coury and I are doing, and he's going to talk about. But the sphincter repair doesn't have the same durability. And it's unfortunate that most of the time, if you do an artificial sphincter repair, overlapping sphincteroplasty, most of the time within, you know, 5 to 10 years, those are going to not be as effective. So, you know, historically, we've done some things that are, you know, over the top, more aggressive. And as we've gotten away from those, we found that some of the newer technologies that we'll talk about seem to be more successful, less invasive, and patients like them better.
So moving on to the minimally invasive now that we were talking about, that's where we get into this InterStim device. It's a sacral nerve stimulator. And basically what it does is, as I mentioned earlier, remember we talked about that bowel control pathway, the nerve pathway between the brain and the rectum. So that's what this uses. This device uses that pathway. It uses your existing pathway, your existing nerves, your existing muscles, and it creates a continuous stimulation to those sacral nerves to provide that continuous stimulation to the pelvic floor muscles. And it's safe, it's effective, it's been used for 10 years, it's done in tens of thousands of people already, and it really does help significantly improve the quality of life. They've come out with some new devices. The newer devices are completely safe for MRIs. There are two devices that are described here. You can actually see these pictures, the smaller one and the larger one. The smaller one that you can see here is the rechargeable device. That's the newest one out. The good thing about this is that it's small. It lasts for about 15 years or so in terms of its battery life, but you do have to recharge it about once a month using an external device. Whereas the larger one, it's not that large. It's the one that's been tried and true for about 10 years now, but it's a recharge free. So once you set your settings that work for you, you don't have to recharge it. You just leave it there, and it lasts about 8 years or so before the battery has to get changed. So those are the options. So in terms of how it's done, the nuts and bolts of it, basically it's done in 2 different outpatient settings. Okay, the first procedure is basically a trial phase, a test phase, because we don't want to put a permanent device unless we know it's going to work. We want to make sure that this is going to work for you. It might work in the trials, it might work in the studies, but we want to look at the individual approach and make sure it works for you. Because what we do in this trial phase is we place a small lead. It's above the tailbone, just below the waistline, and we leave that little external lead for about 2 weeks, about 3 to 14 days. And we ask you to do a journal. Basically, you look at your daily symptoms and you say, okay, am I having accidents or am I not having accidents? Has this improved my life or has it not? So you come back after those 2 weeks and you say, is it working or is it not working? Most of my patients, I would say pretty much all of my patients have gotten that success within that 2-week trial period. They immediately find that success. And so we go back and we do the second procedure where we place the permanent device under the skin. As I said, the generator is under the skin. It's hidden. It's below the waistline. No one has to know it's there. It's completely, it's kind of like people who have a pacemaker where they have that placed on their chest. It's similar, but this is in the upper buttock. And the great thing about this is that it's completely programmable. You can change the settings, you can increase the settings, you can decrease the settings, you can turn it on, you can turn it off, whatever works for your lifestyle and whatever works to help you prevent the accidents that you're having. So as I said, the results are quite proven. The studies have shown that this works in about 90%, 89% of patients have success with this device. They define success as a 50% reduction in accidents. So for example, if you're having problems about once a week where you have an accident, after this device, it'll be about once every other week. It's not perfect, but the good news is for about 30% of patients, they obtain complete control after this device. So while the majority of patients achieve about a 50% reduction in accidents, 30% of patients achieve complete control. And that's really reassuring, especially because this does work in conjunction with fiber, bulking agents, Imodium, those physical therapy exercises I said. This is not a cure-all, but this is the best thing we have, and it works really, really well. As I said, it improves your quality of life. It's been shown to reduce embarrassment, depression, improve quality of life, and it is FDA approved and safe and effective. So you might want to talk to us about whether this is right for you individually. We can discuss that in the office. We can, like I said, do the evaluation, make sure we get your proper history and everything like that that Dr. Gentry was mentioning, and make sure that this is a right device for you. So I'd like to have you watch a short little video about this, and it's a little testimonial, okay?
I found out about InterStim therapy because I had a major event in my life with bowel control. From the bathroom, I called my doctor's group that I had been with for years, who were colon rectal surgeons, and said, I've had an episode, because I was so embarrassed I couldn't even say what had happened because I was in a public ladies' restroom. And I said, I've had a bowel episode and I need to be seen immediately. And they said, is tomorrow morning soon enough? And as the doctor heard about what I'd gone through the day before and how my life had progressed, and he looked at my rectum, he said, you know, I think there may be an answer for you. I went into the test phase for the InterStim therapy, which was very easy to do. I went in as an outpatient to a hospital, and the lead wires were implanted through my tailbone, and I was given a little control stimulator that I had a little computer type wire that came out, and I carried my little outside stimulator control so that I could adjust and fine tune from where the doctor thought I needed to be preset at, but I could fine tune the control. And to my absolute joy and delight, it worked the first day. I went home and it was so cute because my husband would say, do you need to go to the bathroom? have you gone to the bathroom yet? I haven't seen you go to the bathroom. And it was just really joyful to go through and find I'm not living in the bathroom. I'm having a life. And I went back for my recheck with the external control unit and was told I was scheduled for surgery 2 days later because it was a success for me and that I was considered a positive person to receive the InterStim therapy device. It very much was a no-brainer for me. I had the full realization through my big event where I soiled myself and where I'd been sitting in front of 100 people, that something needed to improve, and I'd been fooling myself for quite a while. I was a good con artist for myself.
So JJ, you're on mute, and I'm going to go ahead.
I want to thank you all again for joining us. So you want to, this is, you can make an appointment today. This is our group, Dr. Gentry, myself, Dr. Peter Miller, Dr. Vornberg, and Dr. Sharon. This is our phone number over here. And I want to thank you all again. There's some frequently asked questions that people have. Does the therapy work long-term? And yes, it does. As I said earlier, that 89% that I quoted earlier, that was a 5-year trial. And as I said, this has been going on for over 10 years and those trials are still going and it works really well in the long term. The only thing that I would say about that is that the generator does have to get changed about every 8 years or so, depending on your settings. Next question is, will it cure my condition? It usually provides effective relief. It is not a cure. As I said earlier, this is working in conjunction with fiber bulking agents, other things like that. Another question we get a lot is, what does it feel like? Well, you'll feel this sort of tingling sensation in your rectal area or the perineum. It should not be painful. It's something that you tend to get used to over time. So you may change the settings and you might feel that pulling or tugging sensation. And then after about 10 to 15 minutes, most patients don't even know it's there. They just go about their lives and don't even realize that it's there. So the only thing that you really need to be monitoring is your incontinence and the episodes of incontinence to see if we need to change those settings. Medicare and private insurances tend to cover this therapy. And as I said earlier about the MRIs, the newer devices are fully compatible with 3 Tesla MRIs. So with that, I'll ask Russ if there are questions that we need to answer.
Yeah, so Dr. Coury, there was a few questions that were posed, and I think we'll start with the lower hanging fruit first, and that is about conservative approaches about what can patients do specifically to improve the condition. I think the first thing is, after you meet with us, is knowing knowing really what our impression is of the problem, and if that's a non-surgical conversation, like some people come in and they need surgery for let's say a hemorrhoid or something or a prolapse or something that's causing incontinence that's not going to get better with any conservative measure. Once that's out of the way, if conservative measures are an option, the first thing is, high fiber diet, 25 to 30 grams a day. Sounds simple. Sounds easy, but some people really don't know that. So a food diary, a daily diary regarding what you eat, how many fibers, how much fiber you do is fine. We have dietitians. We send people to dietitians, and that is very helpful sometimes to find out what you're eating is this good or bad. What is the issue? The other issue that can be used for conservative measures is anti-diarrhea medication. If incontinence of loose stool is a problem, the Imodiums and some of the prescription medications exist for a reason. And so we will start folks on anti-diarrhea medicine. How much do you take? Well, it depends on the person, but 1 to 2 tablets every couple of days or every day, and then you can sort of doctor it out a little bit in terms of how much you need. The other thing is physical therapy. We talked about that briefly. And, physical therapy has, like any other field, has specialties. And we have specialists who, deal with pelvic floor dysfunction, urinary incontinence, fecal incontinence. And so they have particular maneuvers that we encourage and we recommend. And, 80% of the patients who I send to physical therapy as a part of their conservative approach get better.
I agree with all that. And the one thing I would piggyback on is, in terms of, making recommendations, of course, online, it's tough to do, is that, we want to make sure we get to the why first. So we can obviously do these conservative recommendations before your office visit. Looks like you're coming in mid-December. But the big thing once you come here is we need to get to the why. Why do you have fecal incontinence? Because we want to make sure that you're up to date on your colonoscopy. We want to make sure that there's no other cause of your fecal incontinence. Like Dr. Gentry mentioned earlier, you could have just very large hemorrhoids that are causing smearing and accidents and things like that. So there's lots of things. I mean, a lot of my patients that have rectal prolapse don't even realize they have rectal prolapse, but that can cause incontinence, the prolapse itself. So there's things that we need to do to sort of get to the why first before we completely make those recommendations. But before your office visit, I think those are all excellent recommendations.
Question about
Dr. Coury,
go ahead.
I'm sorry. Yeah, one of the questions that came in was, what about going through airport security?
Oh, that's a great question. So when it comes to going through, if you're going through an MRI scanner or airport security, one thing that I would recommend doing is just turning off your device before you go through it. Going through the airport scanner or getting an MRI is not going to jostle the lead or mess anything up. It may change the settings slightly. So that's not something you want to have happen if it's going to change those settings. So what I generally recommend for patients that are going through airport scanners or MRIs is just turn it off and then turn it back on. Like I said, there's an easily programmable device that you'll have that you'll be able to turn it off and on quite simply.
Dr. Gentry, anything to add there?
No, not at all.
All right, so another question came in, maybe more specific to this person is, I've had this device and I've found some success. What other options are available?
What other options are available besides the sacral nerve stimulator? Is that what you're asking?
Yeah, I think that's one. And I guess specifically talk about reprogramming with that.
Oh, I see. Yeah, so in terms of other options, usually when we get the sacral nerve stimulator, that's the next step after the conservative therapy. So once we do the conservative therapy that we talked about earlier, we move on to the sacral nerve stimulator. And yeah, the great thing about that is that there's 7 different programs within that stimulator. What that stimulator does is it works on a different part of the nerve. And unfortunately, there's no scientific way of knowing exactly what part of the nerve we need to target to get you the optimal results of fecal incontinence. It's almost like a trial and error. So what we do is we change those settings around. We can go from program 1 to 3, 4, whatever we need to do. And we kind of do this trial and error method. And we can increase the settings, we can decrease the settings, like I said, in terms of the actual amps that it's providing you. And so you can feel that sensation. But like I said, it should never be painful. So then we move on to that. If that doesn't work, then we have to talk about other things about diagnosing what's going on. Now, as Dr. Gentry mentioned, the last step is a colostomy, but that's something that is way down the line and almost never done anymore for fecal incontinence.
Just another quick reminder, if you have questions, just type those into the Q&A function there. One that came in was, how often will the internal battery need to be changed? I think we've kind of addressed that before.
So if your settings that you require a higher amount of amperage to obtain that control, you may have to get your battery changed a little bit sooner. The soonest I've seen is probably about 5 to 6 years. But most patients can go about 8 to 10 years. And then if you get the rechargeable device, it can go up to 15 years, it can last. And once again, the battery changing is a simple outpatient procedure. It's very similar to the ones you had before. It's about 15 minutes. It's under, not general, sorry, light anesthesia, kind of like a similar anesthesia that you would get for your colonoscopy. And so, yeah, it's a pretty simple outpatient procedure to get that done.
I had a question today about someone who had the InterStim, and the patient had an older device that was not MRI compatible and was concerned about getting an MRI and needed an MRI. And I think that was a good question that now the new MRI compatible devices have. And I think it's reasonable to consider a exchange of the battery from the older to the newer MRI compatible in those cases. So that's sort of a red herring question. Another question about the InterStim, about, do you still need to take other medications and do the other things? I think that's a very important piece of this, is that even if you proceed and are good candidate for an InterStim, you still need to do the other things that you've done before. High fiber, if you need Imodium, sometimes people have irritable bowel. That's very challenging to manage. You need to keep doing those things. They are important in this whole sort of multifactorial approach to continence. So yeah, don't forget the underlying conditions. There's a question about not being able to be on a high fiber diet because of a concern about obstructions. And there's some other issues related to incontinence, bladder incontinence. So I think, in those cases, that's really where you need to get into the specific details with your doctor about, treating the underlying conditions. So I think the InterStim is, may have a place in that situation, but certainly not until you address the other concerns.
Yeah, I agree. And when it comes to that, it was the bladder incontinence. It does actually, this procedure is actually FDA approved for not only bladder incontinence, but also overactive bladder syndrome. So, the device was actually designed for urinary incontinence. It actually was found to be 83% effective in women, or in patients, all patients with urinary incontinence. So when they started placing these devices, they found that it works for both bladder and fecal incontinence. So for a lot of my patients that have both bladder and fecal incontinence, it actually really works well for those patients quite a bit. It can work for both syndromes. And I see another question about taking Imodium AD with the device. That is totally safe and accepted. Yeah, to do that, you can take Imodium with the InterStim as well, because all of these things work in conjunction with each other.
All right. Any other questions for Dr. Coury and Dr. Gentry? You can just type those into the Q&A function down there. Once we finish everything up here, you will receive a survey that has a few questions. If you don't mind answering those too, that would be very helpful for Dr. Coury and Dr. Gentry in the practice. Okay, looks like we've gone just over an hour, or I'm sorry, about 45 minutes or so, and with this. So Dr. Gentry, Dr. Coury, thank you guys so much for your time and presentation. Great information to share with everyone. I think that is just about it. Any last bits of wisdom from Dr. Gentry, Dr. Coury?
Oh, thank you all for listening, and yeah, give us a call if we can talk more about this privately, though. Thank you very much for listening.
I agree. And please come to talk to us and see us, and we'll be glad to help you through it. Thank you very much.
Thank you.
Thanks, everyone. Have a great evening. Take care.